We have our next speaker, Dr. Mohammed Leila, and he's going to be talking on multi-layer flap as technique for large and traumatic holes. On to you, doctor.
Thank you, Dr. Ramamurthy. Good afternoon, and thanks to the organizers for the invitation. Um, Full thickness macular hole is defined as the full thickness defect in the neurosensory retina from the ILM to the RPE. Classically, the term large macular hole has been reserved to those holes whose diameter exceeded 400 microns as per the classification of DAS and the International Visual Macular Correction Study Group. More recently, this cutoff diameter has been raised so that a macular hole has to have a minimum linear diameter of at least 500 microns to be considered a large hole. Large holes could be primary or secondary to trauma, myopia, diabetic fractional membranes, beroofed cystoid macular edema, or solar injury, among others. By far, trauma is the most common cause of secondary macular hole, presenting 9% of all holes. And traumatic macular holes usually develop following blunt rather than open globe injury in a ratio of 9:1. Traumatic macular holes, in most cases, develop immediately after the trauma. While the accepted theory is the trampoline effect, in which there is sudden shortening the anteroposterior axial length of the globe upon impact, with equatorial expansion and flattening of the posterior segment, followed immediately by recoil back to the baseline. This produces a tangential traction over the macular area with a less mobile vitreous, causing it to snap at its weakest point, which is the fovea. Another theory is that the different parts of the retina has differential elastic properties, where the fovea being the most elastic, hence most prone to deformation upon and rupture upon extreme stretch. Less commonly, traumatic macular holes developed based on other trauma is caused by dehiscence of the ILM with inflow of the fluid, vitreous hydration of the inner retina, cyst formation, and eventually macular hole. There are certain prognostic factors that herald the final visual function in case of surgery for traumatic macular holes. In general, at baseline, a poor visual acuity, a large ellipsoid zone defect, and a low macular hole height are associated with poor visual acuity 6 months after surgery. Traumatic macular holes are known to have a relatively higher incidence of spontaneous closure compared to the primary variant. So whenever we are faced with a group of factors as small size of the macular hole, absence of intraretinal cysts at the edges in a young age, we can observe the patient and wait for spontaneous closure, providing we perform serial OCT exams. Spontaneous closure generally is a slow process. It can take up to 12 months. However, waiting that long could risk irreversible damage of the photoreceptors, and again, the question of amblyopia in pediatric patients. So most authors would agree to proceed to surgery if spontaneous closure was not complete by 3 months. In cases of macular holes less than 500 microns, this could be managed using the classic approach, vitrectomy, ILM peel, and gas tamponade, or an alternative ILM flap surgery. More than 500 microns, the classic surgical approach invariably yields inferior outcomes with higher incidence of initial failure, late reopening, flat open configuration, incomplete or failed restoration of the ellipsoid zone. For this particular type of holes, we have introduced the technique of a multi-layer ILM plug in the year 2020. The technique consists of creating multiple contiguous breaks in the ILM, 360 around the holes, starting at the point of the hole, usually double the size of the hole. These breaks are then connected together, forming a rosette fashion ILM flap. Then under perfluorocarbon, the ILM flap is carried centripetally towards the hole until reaching the margin and left tethered at the margin of the hole, and then start stacking the hole in a multi-layer flap fashion over the surface of the hole, taking care not to tuck or insinuate the flap inside the hole to avoid damage of the RPE layer. This technique is versatile and could be performed by a number of instruments. The brace could be created using the Thanos scraper or using the finesse loop, and the centripetal dragging of the ILM could be done using the Thanos scraper by the end gripping or the ILM peeling forceps. The mechanism of action of the MEP technique is that in addition to the relief of the anteroposterior traction on the margin of the hole by vitrectomy, the mechanical centripetal dragging of the resultant ILM flap toward the hole reduces the size of the hole intraoperatively. And again, during the process of peeling of the ILM, the shearing of the full place of the molar cells and the remnants of the ILM attached to the margin of the hole help inside the glial proliferation process in order to fill the hole. The multi-layer configuration of the ILM plaque, the stacking of the ILM in multiple layers over the surface of the hole helps keeping it in place. These layers tend to stick to each other and won't be displaced intraoperatively during fluid exchange or later on post-operatively. Again, the undersurface of these multi-layers contain remnants of the molar cells that help replenish the hole and form a scaffold for glial proliferation. We had 15 eyes of 15 patients in our study. We had a mean hole diameter, minimum linear diameter of 700 microns and preoperative best visual acuity 0.06. The most common category of holes were the primary fold, but traumatic. Post-operatively, we had improvement of 5 lines of vision and over mean follow-up period of 4 months. We had 93% U-type closure and 7% V-type closure. This is an example of a U-type closure of the hole with almost complete restoration of the outer retinal layers. Please note the multiple layers of the ILM stacked over the surface of the hole. That's another example of the U-type closure of the hole with almost complete restoration of the outer retinal layers, which is reflected in the improvement of the fixation stability and the macular sensitivity in microperimetry. That's another example of a U-type closure, though with incomplete restoration or actually failed restoration of the outer retinal layers, and hence the patient had unstable fixation and poor macular sensitivity despite of the hole closure. That's another example of a V-type closure of the hole progressing to a U-type closure by 11 months after surgery. Still this partial restoration of the outer retinal layers, and so we have like an island of a juxtafoveal island of improved sensitivity and fixation, whereas the rest of the remaining parts of the macular area have a poor sensitivity. In comparison to literature, we had a hole diameter, mean hole diameter of 700 microns, 93% U-type closure with 0 flat open configuration, and an improvement of 5 lines of vision. So accordingly, we can.
1 minute left.
Yes. So accordingly, we recommend the MIP technique as an effective in promoting macular hole closure and improvement in visual function in this category of holes. Thank you very much for your kind attention.
Thank you. Thank you. Very nice depictive photographs. Video.
Extremely well presented, sir, and thank you for introducing to this technique. Sir, even Dr. Heb also was mentioning, once we remove the ILM, the retinal pliability increases so that the edges of the macular hole reapproximate and restore the anatomy, and we can have a better visual outcome. So having a multi-layer, does it interfere with this reapproximation of these retinal edges and causes any problem, or is it also a source of future traction, or this has been working really well in your study, or was there any reopening of the holes or anything like that?
No, I wouldn't think that the multi-layer configuration interferes with the approximation of the edges, because actually these layers are not insinuated inside the hole. Rather, they cover the surface of the hole and act as a scaffold for the proliferating cells.
Can I ask a question? So primarily, this requires the use of PFCL during your surgery, because that's the only way that you can keep the flaps.
Yes,
we do a similar technique, but because we don't use the PFCL, the flaps just move around when we do fluid air exchange. So I think that requires use of PFCL in your surgeries.
Yes, definitely. Yes, definitely. Yeah, I understand your the other technique. I think it was described by Cassini, is the floating island flap technique, where it depends on the incoming flow of air in order to fold the flap to cover the hole. But yes, our technique definitely requires perfluorocarbon use in order to better locate the flaps over the hole.
Sir,
Sir,
Amandeep, sir.
yeah, I have a very, I always keep wondering what happens to these flaps. I mean, eventually I have patients, the flaps are there for 13 months, 14 months. So what eventually happens to the ILM? Where does it vanish?
Actually, on serial OCT exam, especially when you cross the cutoff time of 6 months and more than that, we don't see them that clearly anymore. I don't know what happens with the LM. Probably it got integrated in the retinal tissue, but I don't know. I don't know what happens.
Because I always wonder what happens to
on OCT after a while. We don't locate it actually that clearly as we do immediately after surgery.
Because we don't see it in the vitreous cavity. I mean, is ILM supposed to disintegrate with time? I don't know. I really don't know actually. So I'm not a very fond of this. I don't know. Really don't know. If somebody has the answer, Dr. Muralidhar, Dr. Hemant.
No, we do see them in the initial post-op, but later on it doesn't remain. So I'm also
Multi-layer also, sir.
Yeah, all this doesn't seem to be there. When I've seen initial post-op, they do present, they are present, but later on I don't see them. So very tough to say what happens to them in the long run.
Yeah.
Dr.
Actually, they fuse over the retinal surface, because we've seen patients more than 36 months or even 24 months, they start to disappear. What happens if you magnify the images and you do a serial OCT, you find that they stick to the retinal surface and they're part of the retinal fluid. So when they curl in, the same thing happens at the edge of where you peel. Initially, if you look at the edge where you initially peel, you might see the edge of the ILM itself. Then by time it fuses over the retinal surface.
That's right.
Dr. Barbara, I have a question for you.
Good morning.
Firstly,
Hello, good afternoon.
Good afternoon.
Ma'am, do you have any, like Dr. Herb has described this technique, and do you find in a persistent macular hole, is there any other technique which you resort to, or multi-layer or free flap technique is the one which you go to?
We don't have the answer on which one is best, because we need a surface to cover the hole. And you've already said in how many ways it has been tried. But one point is the anatomical improvement, and very different is the functional improvement. So if we are not able to really close the edges of the hole in the U shape, we will not have a functional improvement. So I'm probably adding one more variable, which is the hydrodissection of the macula. I don't know if some of you already spoke about that. Hydrodissection of the macula and reapposition of the edges of the hole by stretching the edges of the hole, and then ex vacuum with the fluid air exchange, really closing the hole. I'm doing that in persistent macular hole after the first surgery. I'm adding the macular buckle just because in high myopia, when you manage the macular hole, you might have, you can close the hole, but you could detach the macula. So what I do, my favorite technique is to hydrodissect the macula with injection of subretinal BSS, placing a macular buckle and closing the hole over the top, even without anything inside. I think that's the only way to achieve a functional improvement as well.